It's good to see you all. Apologies, I know Precious has given her apologies. And that's it. Yeah, okay. Thank you very much. Any declarations of interest at all? Bobby, I'm Gary as well. Yes, I think he's hoping to, come in from Australia. That may not be possible. Okay. Thank you very much. Any declarations of interest at all? No? Good. Thank you very much. We'll go on then. Welcome, Sharon. You're doing the patient stories today?
Yes, I am.
Lovely. Good
Thank
to see
you.
Thank you very much.
So good morning, everybody. My name is Sharon Robertson. I'm the matron for patient and family experience. But for the last 6 months, I've been covering learning disability and supporting that role. Mark Story is a patient who has a learning disability, and he sends his apologies because he really wanted to join me today, and the plan was to bring him to Trust Board so he could tell his own story. But when I saw him last night, he was super nervous and felt like he couldn't manage, but he's more than happy for me to tell his story. So this is Mark.
So can I just interrupt you? If you guys want to move your chairs and come round, the
So this is Mark. He's a 39-year-old male who came through our organisation with a problem with his umbilical hernia. So he had been under the surgeons, probably not directly under the surgeons, he had been referred to have an umbilical hernia repair, and he had tried really hard to lose the 4 stone. He'd lost his 4 stone and he was on a waiting list to have his surgery. However, he then developed a complication and had to come through as an emergency. So he came through the emergency department, he came through the new SDEC, and then to Ward 21B, theatres, Ward 20, and then discharged home. So I met Mark on Ward 21B, and I was pleased to know that, well, I'll let you know that Mark, his dad died when he was young, and his mum died 2 years ago. So he has no family at all, except the carers and staff at Heavy Down, where he lives, just in Bean Hill. So I was delighted to hear that the staff on Ward 21B had already made reasonable adjustments to allow him to have visitors out of our normal visiting hours. So that was really good for Mark. So when I met Mark, we phoned Alison, who's his main carer at Perry Down, as he wanted to update her with what the plan was. When he put down the phone, he said, I should have asked her to bring my teddy. So I said, I may be able to get you a teddy. What's your favourite colour? So he said yellow. So off I went to the children's A&E department, where I explained the story to one of the nurses in the bed. She found the yellow teddy, and when I told her he was having an umbilical hernia surgery, she wrapped the bandage around the teddy's tummy, so it mirrored what he was having. Mark was over the moon with Teddy, and he kept it with him throughout his journey. I popped round to theatre just to make sure what time his surgery was due, because he was getting anxious about when he was actually going to get the surgery. He was worried that he wouldn't get surgery because he'd been waiting a while and being prepped for that. So theatres were great. Karen said there's 2 emergencies in front of him. He may not get done today. It may be that we carry it over to the next day. So that was great because I was able to prep Mark with that information. And true to her word, he didn't get done that day, but he was done the next day, and he was fine with that. He'd built up a really good rapport with Jess, one of the healthcare assistants on Ward 21B, who used to work in theatre. So she took him to theatre and waited in the recovery room with him. So Mark actually called his teddy Tim after one of the people. He couldn't say what role he did, but it was one of the people in the anaesthetic room was really kind to him. So that's why Teddy is called Tim. So Mark did really well on 21, went back to Ward 20 post-op and made a really good recovery, supported by the physio team. They gave him an abdominal binder. He was all ready to go home, but there was going to be a delay in transport. So I booked a hospital taxi, jumped in the car with Mark and took him across the road to Perry Down. So he got home with all his belongings, could hand over to the staff about his medication and about how to fit the binder. So that is an overview of Mark's story. What Mark actually said were his words, that his experience was really, really good and the people were so polite and everything. The people on the wards were nice. Some of them spoke to me and asked me what my problem was. I called the Teddy Sharon gave me Tim after one of the people in theatre because they were really kind to me. He even said, I hope you get better soon. I asked Mark if there were any improvements in his journey we could make. He said, no, they all do a fantastic job and I'm getting better. And he's just so pleased now that he hasn't got this huge bulge where his umbilical hernia is. He's got a flat tummy, so he's just so happy. So while I'm here, I thought I'd take the opportunity just to briefly talk you through learning disability nursing and what I think the role of the nurse is. So obviously to support patients, their carers and family and provide regular updates. I think the learning disability nurse complements the ward staff to provide inclusive care and role models effective communication. Sometimes the jargon we use isn't always filtered down to the patient's understanding. Use the appreciative inquiry tools to discover what matters to patients when they access hospital, and make sure that the patient's voice is heard. Coordinates discharge planning meetings to ensure safe and efficient discharges, and works collaboratively with external stakeholders to enhance patients' journey through the hospital. So this is brand new. You're the first guys to see this, and we work really closely with patients, carers and their families. They chose this symbol, and this is going to be our learning disability symbol that we hope to roll out across the trust. It will be displayed on the whiteboards behind the patient's bed and also in the whiteboard handovers. Just as a visual reminder, like we've got the dementia forget-me-not, this is a visual reminder just to remind staff that reasonable adjustments might need to be considered. Oh dear, sorry about my slide. It's better on that one. We'll look at the middle slide. So work experience opportunities. I also lead on the volunteer team, and we've been working really closely with Talkback and McIntyre, who are local charities with their job coaches to get employment for people with learning disability. So we've had to kind of work a bit differently with our recruitment. We had to work closely with the job coach to find out what the person is interested in, and then speak to an area or department to see if there was any work that is suitable for them, and then do the recruitment back the wrong way. So then invite them in to have a meeting to discuss the role that we think would suit them and see if that is actually the case. So we actually get a 2-for-1 because they all come with a key worker. So we get 2 volunteers for the price of 1, which is great. And we have 3 volunteers starting really soon, which we hope will give them work experience and hopefully in the future may lead to paid employment, whether it's here or elsewhere. At least they've got this to put on their CV. So we've got Liberty, who is going to bring her Teddy and will be volunteering on Ward 5, doing a snack and hydration round. Kieran, who's going to offer ward support and be a ward support volunteer, and Jack, who will be a yard support volunteer. I know that sounds a bit dodgy, but it's not supposed to be ward, it is supposed to be yard. Jack's got Tourette's and can't be patient facing for obvious reasons, so he's more than happy to support the team in the yard, and we'll see how that all goes soon. So we've just submitted our learning disability NHS benchmarking for this year, and these are our improvements that we've worked on since last year's benchmarking. So collaboration with local care homes and getting to know people in their own environment. And that's been key because recently we had a patient in on Ward 16 that I went to visit. Because I knew her from her home environment, I knew that Noddy, the toy Noddy, was really important to her. So when I got there, she's laid in bed. just looked bored. So I said, "Oh, hi, Jackie." I said, "Where's Noddy?" And her face just lit up. Had I not known that I'd visited her in her own home, we wouldn't have known that. So her face lit up, and I found Noddy because I knew that Sam would have packed a Noddy for her. So found that in her bag. So then we played with Noddy. I think the international nurse thought I'd lost the plot completely because Jackie kisses Noddy, she throws him across the room and says, "Noddy on the floor." You then pick it up, and this is like a repeated, but she has the best fun doing this. So eventually the international nurse joined in, and I said, "Anytime you've got a spare 5 minutes, go and play with Noddy and Jackie." And that just made her day. So yeah, we've also created bespoke pathways for local residents, one that lives at Howe Park, who frequently attends. She's got autism and a learning disability and mental health on top of that. So she often comes in mental health crisis. She doesn't really need to come to A&E. She just needs to be seen by the mental health team. So we've created a pathway that kind of cuts that bit out, and she gets directly referred, sorted and sent back. She requires 3-to-1 care, so it's unsafe for her to be in hospital for the time. So they're just two examples. We're also working closely with care home residents, staff, to get to know their patients by putting their hospital passports on in-care for all staff to access. Flagging for learning disability patients is ongoing, and obviously the flexible and inclusive visiting that I already spoke about. Nearly there. The middle one, yes. So the work in progress is our gap analysis from our benchmarking and training for all staff. This year they're bringing out the Oliver McGowan and mandatory training for all NHS staff. But on top of that, we want to do something that means something for our patients and our staff. So we're in the process of putting together little short videos of what matters to patients when they come into hospital that we can share at training. We're also in the process of recruiting a Band 6 learning disability nurse, which will be great for me, and having I've got a couple of patients lined up who want to be on the recruiting panel to support the interview process. We're working with patients, families and carers along with the medicine and surgery divisions to create pathways for scheduled and unscheduled care. So that's a big piece of work that's in progress. We've already started in the children's A&E department working through an unscheduled pathway for children. And improving our written communication with signage patients. I'm hearing feedback from them that they find appointment letters really difficult to read. So I'm hoping that we can do something around easy read and start with appointment letters. This is just some of the feedback that the care provider for Mark said about how, let me read it, it's how the links with us and them have developed and improved the care that their patients receive. And I did pop round to see Mark on the way home last night to see if he was okay to come today, and also just to help them. They got a new binder, so they needed help to pick that. Yeah, but he's making a great recovery, and that's it. Thank you for listening to the story, and if you've got any questions, I'm happy to answer.
Thank you, Sharon. That's great. It's great to hear as well that whole sequence of treatment. I would say, I mean, before I ask Colin for something else, so having spent before coming here so many years in mental health and learning disabilities, as well as my years with the both sides of the health sector working so closely together, it's marvellous. And it will make such a difference. Any questions or comments at all?
Really a big company channel. It's really good to hear about the volunteering and then trying to consult with these people having so many yes, ones. Yeah, but it's very good.
And just thinking, because I know Doctor Health, I think there are volunteers with learning disabilities who I haven't know. Do you have a link with them as well?
Yes, yeah, we do, and if we talk back as well, they We've got an artist, one of the people that produced this project, they are an artist, and they've actually created a it's going to go up, I think, somewhere in the trust. So that's been commissioned, and he's making us. And Arts for Health are working now. We've put them two together. So he's now working alongside them. So
Fantastic.
no, that's really good.
That's really great. That's smashing. Any other questions? Hey,
Sharon, amazing story, so thank you for sharing it. Please thank Mark on our
Yeah.
yeah, absolutely.
I think you've answered my question, but maybe you can elaborate on it. I was just wondering about the links to the community and how you kind of maintain the good work that you do here and support the community. And I think you kind of answered it on the last slide, but I was wondering if you could expand on that.
So I guess the learning disability community team are key to supporting not only me but their patients when they come into hospital. But it's just phone calls to the homes, the care managers, the carers, so as we can learn so much about the patient, which improves their journey. Admittedly, I got to know Hal Park through a complaint. But we've built bridges, we now have pathways. But I think having links with all the residents when they're in, you just have to make the effort to get in touch, and they are just delighted to hear from you. I've learned they are so passionate, and they're such amazing advocates for their residents that they are just more than willing to come, and they're more than willing to come in and support the feeding. And, so it kind of works both ways. It's a real team approach.
That's great to hear.
So,
Do we have tools that we share information between the different groups, or is a lot of this kind of done face to face?
Face to face, yeah. And they're happy to invite us into their home, and that's how I met Jackie with Robin and with Noddy. So, yeah, there's and again, I'm more than welcome for them to come in and come and support and see what we do at the hospital. And if we need any adaptation or any support, they're more than happy to give. So.
And it's brilliant to hear that patient representation on the interview panels.
Oh,
Yeah, absolutely.
yeah. I've got a patient that was on ward 1, Sammy, and then McIntyre, they've just got a new nurse at McIntyre at Greathall, and she emailed me straight away and said, I've got 2 patients that are happy to sit on panel to support your interview. And some of the learning disability nurses have also offered to come and sit on panel, because I've not got an expertise. I've just, I've not got qualification in learning disability, just passionate to support them. So, yeah, I've found a new passion in my life.
It's great stuff. And all that relationship building is marvellous, actually.
And I just want to say I'm taking over leading the dementia nurse. We've just recruited a band 7, and I'm hoping that what we've done with learning disability and rolling that out into the community and getting links with care homes, we can do the same thing. Just mirror what we've done here with learning disability with dementia, but that's going to be work in progress.
Brilliant. Yeah, no, that's great to hear. That's great to hear. And yeah, having previous experience of somebody sitting on interview panels, it really brings such a good perspective.
Yeah.
When you are interviewing people, so that's great. Thank you very much.
Thank you.
Well, thank you. Thanks
Thank
very
you.
much for that. Yeah, and thank you to Mark.
Thank you. Thanks.
Bye. Apologies. And I'll invite you back to today.
Thank you.
Now, I'm going to bring the maternity side, as people probably know, in case you don't, we've got the Care Quality Commission in at the moment, these 2 days, yesterday and today, and they're focusing on our maternity services. So Yvonne and Melissa have to be somewhere fairly soon. So we're going to bring the maternity reports to the board now, just bring it up the agenda. I can do the maternity assurance group, so I'll do that under my normal thing. So I think the next one is 10, isn't it? I'm just going to look up item 10, and that's the maternity patient experience update.
Thank you. Hi, everybody. I'm Melissa, the Divisional Chief Midwife at MK. So from a patient experience perspective, there was a report that was included in the pack, and the CQC full report with all the benchmarking details are in there. I just wanted to pick out a few things that we've been doing to look at some of the targeted areas that we needed to make some improvements. One of those is around induction of labour. We recognise that in terms of the discussions that were taking place and informed consent for induction of labour, we needed to do some targeted work. So a couple of things that we've done around that, which have had some really good results, are we now phone everybody who's having an induction of labour. We started this in February, now continuing it in March, to just understand if they know the reason for the induction of labour, if they feel that they've had enough information about it before they come in, and if there's anything else that they would like from us before they come in. The other thing we've been doing is talking about the process. Once you come in for induction of labour, what will happen? Because that is one of the areas that from the thematic review we're doing of those phone calls has already come out as an area of focus in the recognition of what will actually happen once you're admitted, how long you're likely to be with us, and what the process is. So we're continuing to collect those themes and discussing those with the MVP to support some improvements in that area. One of the other areas we've been doing some focus on is birth partners, because there was some aspects around the report of having support from your birth partner at all times when you needed it, and then being able to stay with us as long as they wanted. So in February the 13th, we re-implemented birth partners overnight. We created a co-produced document with the MVP to discuss how that would work and how it wouldn't interact with any of the practices we put into place last year following the survey, such as night mode, which was a new approach to overnight that we put in directly from feedback. That seems to have been very helpful. We've had quite a few partners staying overnight, and I think it's definitely making a difference in terms of the experience. We've been doing some wellbeing walkarounds. So we've targeted these initially at the inpatient ward because we recognised that that was an area where we were associating some more of the negative feedback. So every day, one of the senior team goes up, speaks to both the staff in that area and those who are in the service at that point, just to understand if there's anything that we can do to improve. And we have been collecting the themes from that. We've picked up on a few themes, which are things that we've now added to the overall practice experience quality improvement tracker, so that we can keep monitoring those and assess the experience of those who are using the services there. And we've done some quite targeted work around some of our privacy and dignity areas, looking at how we can support different transfers between different areas, because we recognise that that is one of the points that we need to be very aware of, especially when we're, for example, going from labour ward to theatres, or also moving from the inpatient ward down to labour ward. There's some of the key points. I'm very happy to answer any further questions on that, other than moving forward. What we're also doing is, so that we can have a continuous understanding and benchmark for ourselves, is that Yvonne supported us to add the CQC patient experience questions into Tendable. So when we do those Tendable audits, we can collect that data on a monthly basis ourselves, so it gives us a bit of a temperature for how we are doing before we await having the yearly reports that come out from CQC. The next report from CQC, they are surveying all the women who were birthed in February of this year, so we anticipate the results towards the end of the year.
Thank you very much. Thanks, Melissa. Any other questions at all? Yeah.
I suppose it's questions to Kate and to you in terms of patient experience and I'm going to say PEP, but I don't know if it's not PEP in how it's being used at the moment. What's the name of the company?
The patient experience platform.
Patient experience platform. How does that tie in and give us data that we can reconcile with what Zoe's with what? It's going to be a long day. It's definitely the person. With what maternity?
It absolutely does. So the PEP, so this platform gathers in lots of data from different sources. So from friends and family tests, from comments, from compliments, from complaints, it pulls it all together. It's a really powerful tool. So we just looked at it actually over the last couple of days around what people were saying about maternity. So it gives us a more holistic picture of people's experience, because obviously the maternity survey targets a specific group of women and families who've used the service in a particular time frame. So what we want to do and need to do, what this has just discussed, is building that experience data collection out, so that we're asking women all the time about their experience, which will help us to keep improving and picking up issues quickly.
So just on the back of that, and the reason I said Zoe is that on a serious note, there's a story that will be run shortly around which hospitals have got patient experience platforms in relation to the technology that we have around MyCare and that are linked into the NHS app. That's why I was avoiding using the term PEP, because the PEP, as we know it in relation to patient experience, is different from what the rest of the country know as MyCare and the technology that allows patients to see and manage their appointments online. I don't want the two to be confused.
Heidi.
It was a question really around the birthing partner, and I wonder whether it's are we in a better place than we were in 2019 pre-COVID in terms of what we allow, or are we back to where we were? And I suppose I'm just wondering what the risks are going forward. What would make us have to change direction again in terms of limiting access for birth partners, or do you not see that happening?
So in terms of birth partners staying overnight, we've essentially reverted back to where we were pre-COVID, and because we did have that in place before then. I think a lot of the indicators for doing that is there are particular groups of women who, when they're admitted, really need that service. So, for example, if you're coming in for an induction of labour, we have some quite specific feedback from that. Also, those who come in and have multiple births, it's very helpful to be able to support partners overnight. We did review it and look at the impact that it might have, because we do know that there are some potentially negative impacts on that, such as it can increase noise overnight, it can increase the lighting overnight, it can reduce the amount of sleep that people get overall. There are some people who are less comfortable with having partners overnight. So what we did is looked at how could we model the ward around that. So if we have people who don't want to have partners overnight, we can look at how we use the bays differently. We put in the co-produced booklet to manage this, particularly to support some of those implementations that we've made previously in terms of reducing the noise overnight. And we're also just about to implement something called sleep packs. So this is something that's been picked up from the recent Embrace report around the impact of insomnia on women both during pregnancy and postnatally. And so the sleep packs will also help to maintain the ability to sleep overnight and the ability for rest. From an infection prevention and control, we just discussed it with the IPC lead. We have obviously all the hand washing facilities and the gels which are available for use, and we have put quite clear parameters around overnight stays from an IPC perspective, illnesses beforehand, how long you have to be illness free before you stay overnight, what we expect in terms of IPC practices. And we are at the moment, we have been still wearing masks within clinical areas outside of those bed spaces. So I don't anticipate that we would need to revert that unless there was something really significant.
Because I think there's many elements to it, aren't there? It's not just about choice, about even just about infection control. It's many elements like that.
And it does make a big impact to start doing something and then to need, which is why we were really considered before we put that into place, because that's not an element that you want to be putting it back unless it's pivotal.
Thank you very much.
I might just add on that we're in the process of changing our mask wearing policy based on local COVID prevalence data and hospital prevalence data. So as of tomorrow, a communication efforts around stepping that back, and we won't be requiring staff to wear masks in all clinical areas as of tomorrow. And that's in part because lots of the benefits in Sharon's previous presentation, for example, around patients with learning disabilities, the communication benefits of not wearing masks have to be balanced too. As Director of Infection Prevention and Control, I say, touching wood, I can't see that COVID would cause us to change our arrangements again in the future. Clearly, the next pandemic, if and when.
Thank you for I think that's really good. Just looking at the details of in the appendix, I think from my limited review of it, there's two themes that are coming in. So what we seem to be doing really well is the initial advice and guidance and this information that is provided to the patients. But what we seem to be struggling with is the more reactive. If someone raises concerns, then we seem to be falling short on that one, or the help is needed. That's where we seem to struggle. So is that, in your experience, is that related to staffing levels? Is that a training issue, or have you looked into more details around that, or is that something that we need to focus on going forward?
I think an example I could probably give of that, because it's absolutely right, there are areas where we are being more reactive than proactive in the management of certain aspects. One example of something we've put into place is we're doing some buzzer audits on the inpatient ward. And this is not necessarily about the delay in terms of the time from pressing the buzzer to answering it. It's to understand the reasons why people are pressing their buzzer so that we can actually organise the service to be provided in a better way. And one example of that is we're finding that buzzers will be pressed a lot for things like if you want to go for a shower and you'd forgotten your towel. Well, actually, if we make those things accessible to you for you to be able to get up and get, then it's there for you at the time rather than reacting to going and then you go back and get the towel and then on the way back you see quite a few other people. There are some things around infant feeding, so we're looking at being able to increase the peer support workers for infant feeding, because if you're sitting waiting for quite a while, we do get quite a lot of feedback. Even though it has improved on infant feeding, that is one area that we know we have to focus on. So we are definitely looking at how can we actually organise it in a better way. There is something around training there as well. I think there's something around the way that we're having the conversations, what conversations we're having. Management of pain relief is another thing that we want to look at, because that is associated with a lot of the buzzers as well. And if we can do that in a better way, that's more proactive for those who are with us in the service, so that we can look at a better way of organising that. That is absolutely a focus for us.
So Deb, so I've got some more I could probably add to. We have forensically gone through the actual survey. We've built a series of patient experience questions. So where you've seen those themes, we've gone even deeper than the CQC survey, particularly around induction and that immediate post-birth period. The way we designed the questions in the testing phase is that when we gather the information, it will give the clinical team an opportunity to resolve some of these issues at the point of care. It will also make them much more aware on a day-to-day basis how their interactions might be impacting on individual patients. But as we test through, we'll try and resolve a lot of the issues for the patients as we have the conversations with them in gathering the data and the information, and it will allow us to have more detail.
Yeah, that's good, because usually you sort of see the trend would be opposite, that it's the initial information and advice and guidance where you'd say, oh, we struggle with, but if someone asks for help, then we are always very proactive in providing the support, but it seems to be opposite here as well. Thank you.
I think we're probably at a point whereby we do want to do something specific to the board around patient experience with the work that you're doing at sort of ward level through tender board. We know we've got through the patient experience platform, and so I'm just wondering if we don't schedule something in a couple of months' time, and that would allow the technical staff to gather some data, it's not about maternity, it's around the organisation more broadly, and see if we can't start to pick out some of the themes and really understand at that level whether we're tackling it or not.
Yeah, no, absolutely. Ian.
So I think that'd be a really good idea. I think the other point I'd just make, Deb, is around patient experience in maternity specifically. There's loads of good work going on, as Melissa's just described, but one of the key things also is the built environment. And our maternity and neonatal unit are not as we'd like them to be. And that's precisely one of the main drivers for our new hospital programme in the trust, particularly space in the neonatal unit and also the environment in maternity. So there are lots of things we can and are doing now, but that's sort of the next big step, which is obviously on the horizon, and we look forward to that happening as soon as possible.
Yes. Thank you all very much. Thanks. Thank you, Melissa. The item 14 is a maternity staffing report.
So this is quite a long document, but I'll try and just pick out the main points from the different staff groups.
Yes.
This document, so every 6 months we report the maternity clinical workforce paper as part of the maternity incentive scheme board. It covers a number of different elements in that paper, some of which are mandated by the incentive scheme, some of which are to give you more of an overview and an intelligence into staffing within this area. So I'll just pick up on a few key points. So from an obstetrics perspective, we have updated the RCOG roles and responsibilities document. There have been a couple of changes to that this year. So we've updated that and we do monitor that through the governance report monthly. We have just this month, we are about to remove the risk on the risk register around obstetric staffing because we've managed to fill those gaps in terms of the rota, which is a really good news story. From anaesthetics perspective, we are currently completely compliant with the ACSA standards. Neonatal nursing, we have done the neonatal nursing gap and workforce tool. We have had good recruitment within the neonatal environment. The area that we're doing some focus on is QIS trained, and that is qualified in specialty. So for our unit, when we've looked at the workforce tool, we need 70% of our nurses to be qualified in specialty. We're currently at 64%, and we've got 4 more who are on the training currently. And once they finish the training, we'll actually be over the 70%. This is just to ensure that we've got the right level in terms of skills and specialties for each shift. We are looking at some triggers within our neonatal workforce. So one of the things we're trying to do is to support within rotations in the paediatric environment, because sometimes that can be associated with some poor staff feedback, especially from those who are new to the neonatal environment. So we're working very closely with paediatrics in order to do that. So the midwifery workforce, which takes up quite a bit of the paper, there are some main aspects within there. So it details Birth Rate Plus. We had a new Birth Rate Plus report that was published in May of 22. So this is something that we do ideally every 3 years, and it looks at your acuity of all the women who use services and essentially benchmarks and sets what your staffing levels should be. One of the main aspects was that we had a 10% increase in the acuity of our women overall since our last report in 2018, which is quite a significant increase. There's information about the planned versus actual midwifery staffing. You'll see in there that this is done on a monthly basis and it covers the whole service. So the reason we don't break this down into individual areas is because of the dynamic movements that happen in maternity of where staff will go to cover the activity on a daily basis. We need to look at the overview of where we are with that to understand the impact it's having on the service. Midwife to birth ratio is also reported in there, as well as some other workforce around percentage of specialist midwives. One thing that's probably worth noting is we are doing a piece of work where we've mapped all of our MSW and MCA workforce. So there is a regional and becoming national movement towards upskilling to band 3 MSWs within maternity. So the regional job descriptions have been approved. We've put them through the job matching process at MKUH. And there are very clear parameters in terms of competencies for band 2 MSWs and band 3s. The reason why this has come into place is it's put a career pathway and progression in place to go from a band 2 to a band 3. There are now band 4 MSW roles, and then it's starting to look around the midwifery apprenticeship roles, which we've opted to try and have 3 spaces for that from September as another pipeline into maternity. So we've mapped all of our staff members, we've got an allocated training provider and a pathway in place for them, and that will really help with the career development conversations that we have with that particular staff group. We also report on the supernumerary status of labour coordinators, and just to draw reference to the 4 aspects that you can see in the appendix are essentially action plans around maintaining compliance with supernumerary status, the action plan around maintaining our compliance with 100% one-to-one care in labour. And also there is the workforce tool that was used to map how many of our neonatal workforce we needed to be QIS trained, and the action plan around both QIS for neonatal workforce and also for our medical neonatal workforce. We need to now be compliant with Tier 3 as part of the maternity incentive scheme. And that means that the consultants have to cover the on-calls in neonatal services for 4 weeks every year. So we're doing a bit of mapping around that.
Thank you very much.
Can I just make a quick comment? So having a look at the paper as a whole, it's really important to understand, particularly around our fill rates. how we approach that. We have very safe and efficient bill rates, despite sometimes the number indicates. The way we manage and mitigate that is, for example, on Ward 9, we will redeploy RNs to maintain that one-to-one care in the labour ward and to keep the supernumerary status in labour ward. So there are different and other creative ways that we manage the staffing risk across the broad spectrum. So we don't just look at maternity, we look at it trust-wide.
Yeah, and I think just in terms of commentary about the CQC coming in, it's important for people to note that at the end of the inspection, the on-site inspection yesterday, there were no significant safety concerns raised. So I think what we're seeing in our paperwork and what we've seen from the CQC is we know we're safe, we know we've got more to do, and we won't know formally from the CQC for some time, but they always raise significant safety concerns on the day if they have any, and they haven't.
Well, just make another comment. So when we're talking about the availability of staff, you know, that managing within, we have a statement around headroom. We're doing a huge piece of work with all of the clinical teams, both in maternity and across the trust, with our colleagues in HR and in e-rostering, and that's about the efficiency and the effectiveness of the rosters. So some of the things we brought up, you know, about the management of annual leave and the management of study leave, so that it doesn't impact on the safe staffing of the hospital, is a critical piece of work that we're working on at the moment.
And I think, I mean, what I'd like to say is thank you for all the huge amount of work that's gone on, you know, with Melissa, yourself, and London and the team. So thank you very much for that. And I know you've got to, that's the only reports, isn't it, from you both? So I know you've got to go on with CQC today. So thank you both very much.
Thank you.
Thank you. Oh, sorry.
If they need to go.
That's fine. Yeah, time for one question.
Just wondering about any activities you can highlight that we're undertaking to address the kind of inequality gap, the outcome for especially Black mothers.
Yeah, so we've obviously looked at the recent Ambrose report. We've got a number of actions on an action plan around that. I think the other reports that we're looking at are, we have looked at the 5X report that came out, as well as the trans and non-binary report and experiences of maternity care. We've also got the Invisible report. We've mapped all of those reports and looked at particular elements that we can bring into the service in terms of how we can support those improvements. Across the LMNS, we're doing quite a lot of work as well. We've got an equality and equity strategy across the LMNS. And when we've looked at the priorities for moving forward for this year, one of the absolute priorities is around the experience of those using the service, but actually how do we do more to reach those who aren't able to access the service in the way that everybody is. So how do we reach out to some of those communities? We've set up some new services, such as the emotional wellbeing service, which is linked with CNWL, that has some really good referrals into that service. We've got a health and lifestyle midwife who was just put into place, who is looking specifically at some of the areas where we can make some of these improvements. I think the other thing to mention on that is that when we do a lot of the reviews now, we make sure that we include the ethnicity data within those reviews. So, for example, when we do our MOH review group, we have the ethnicity profile in there, so we can see if we've got any areas that we need to focus on.
So what's MOH?
Major obstetric hemorrhage, sorry. So blood loss after you've had a baby, all of the blood losses that trigger at a certain level go through our group. And we look at a huge number of factors to work out, were there particular things that we could have done differently, or a reason why we had excessive bleeding. Another area that we are looking at to be able to map those as well is when we do any thematic reviews. So, for example, when we do stillbirth thematic reviews, or when we do preterm birth, we also map that against ethnicity as well to see if there are any particular areas. And our data digital inequalities midwife has actually built us a bit of an ethnicity-based dashboard, so we can look at the metrics on our dashboard and break it down to those ethnicities within the service.
That's great. Hopefully we can drill down on some of that in the review.
Yeah, absolutely. Thanks, I know you've got to
No
go.
problem. Thank you. Thank you.
Thank you very, very much. And I should say, yeah, LMNS, the local.
Maternity and neonatal system across BLMK.
For BLMK.
Sorry for the acronym.
Brilliant. Okay, thank you all very much. Right, now we go back to the the minutes from the last meeting. Anybody notice any inaccuracies or omissions at all? Everybody happy? Good, thank you very much. So we can take those as accepted. And then we go on to the action log. First one is the significant risk register.
That's my, we just need to schedule in a time for the board in a seminar session on our calendar to do the risk type work. Exactly. We have made some other changes to the risk paper, but that's what's keeping this actually open.
Yes, yeah.
We'll do that.
I know we haven't had that conversation. And then the next one's May, and then 26th work report.
Yeah, so the cost of hire is in the paper, and we took we did a deep dive into retention at the Workforce Committee, so we took all that data to Workforce Committee.
Thank you very much. So we can close that. We'll be talking about that shortly. And that's it. The others are for me, unless anybody's noticed something with this. Okay, thank you very much. We go on to, I've got my report there, just a couple of things to add. I took part in a meeting with NHS England's chief midwife and colleagues. It wasn't just me, there was a whole thing. We were reviewing our improvement plan, and obviously what Melissa and Yvonne have just fed back. You can see there's an enormous amount of work going on there. And also just to say that I chaired the Inclusion Leadership Council, but I'm feeding back on that later on the agenda. So unless anybody's got any questions on my feedback. No? Okay, thank you very much. Joe.
I think this is one of those nice chief exec reports where I don't really say anything. So in order to give the technical people time to get patient survey information up, which I think Danielle's going to present, she's looking at me. I'll hand over to Ian to do the strikes. If you can talk about what we're doing here locally on strike action.
Okay, so in terms of industrial action for the health service, colleagues will know we haven't been hit particularly hard so far, and the ambulance strikes involving the GMB didn't really touch Milton Keynes. There was a positive ballot amongst physiotherapists, but at the moment that particular data has been stood down. The first industrial action to hit us significantly is the junior doctors strike, which starts at 6:59 on Monday morning, and is 72 hours of industrial action by junior doctors nationally. Importantly, there are no derogations, i.e. the junior doctors won't be providing support to emergency departments or intensive care units or anywhere else. So the working assumption is that we have our consultant body and specialty or SAS doctors to rely upon for 3 days and nobody else. Now, clearly, some of our junior doctors may come to work, but our working assumption at the moment is that they won't. As you might imagine, we're in the advanced stages of planning in terms of how we deal with this. There will definitely be significant impact on all of our elective services. And our focus in our planning at the moment is in maintaining inpatient and emergency services, and importantly, maintaining flow through our hospital, because if we don't maintain flow, we very quickly would have an impact on the viability of our emergency services. So those are the priorities. Nationally, the major union, the British Medical Association, is being somewhat inflexible about how consultants and specialty doctors should vary their normal working arrangements during the course of the industrial action. Locally, we have very good relationships, and I'm pleased that at the Joint Local Negotiating Committee, we have been able to agree a framework for how consultants and specialty doctors here in the Trust will vary their work patterns to support our patients. So that's really helpful in terms of putting in these plans. The remuneration arrangements, I'm conscious colleagues will have heard things on national media about the BMA's requests for remuneration. We have reached an agreement which we think is very similar to neighbouring organisations and is not the BMA's published rates. So that's where we are at the moment. Very happy, obviously, to take questions.
Thank you very much. Any questions? A huge challenge across the nation. So thank you for all the arrangements. Actually, obviously, we've got to keep on very close watching brief on how things go.
Excellent. Should we move on to the staff survey?
Yeah. Thank you. So this was only unembargoed an hour ago, so so it was literally hot on the press. So you want to next? So the results, as they were last year, if you remember, are now centered around the people promise. So the 7 themes of the people promise. Our organisation in that, this is the overall table, our organisation is the dark blue bar. The average is the light blue bar. Best is the green and the worst is the amber. So as you can see from that, again, this year, it's really good news. We are consistently above average for our sector. So the sector that we're in is all acute trusts and all acute and community trusts. So anyone who provides acute care. Last year, if you remember, we were we had the top score for staff engagement. I'm really pleased to say we still have the top score for staff engagement. That was 7.3. But this year as well, we've also got the top score for We Are Always Learning. So again, that's really, really good. We're now consistently 2 years on the run with the engagement score and now also managed to lift our learning score. So the way it works is there's a very large number of questions and they feed into those people promise themes, and some questions might feed into 2 themes. This year we had 72, so 69% of our questions were significantly better than the rest of the sector. 30% were about the same as the rest of the sector, and we only had 1 score where we scored worse than the sector. I'll come on to that in a minute, but I think when we talk about that one, we'll all understand why we got that one. So we can move on to the next. So the only one where we were significantly worse than the sector was on average, how many people are working additional paid hours above their contracted hours. Now, as you know, we have our own internal bank here. So people who work bank shifts are classed as doing additional hours, additional paid hours. We know that in order to achieve the percentage of activity that we managed this year, our staff have volunteered to do extra hours to help with that. So that's not a surprise. However, we've said in the board before that we can't continue like that on a long-term basis. But in the short term, we know people have been doing extra hours with the extra initiatives we've been putting in to try and clear some of the waiting lists. So not a surprise, but we have a rationale behind why that is. It's just worth noting, though, that trusts which don't have internal banks, they probably won't score the same because they will class their bank work as being additional employment, not additional employment out of their main role. So the areas where we got the top score, so we're significantly above average in all the people promise elements, as I said, but we've got the best national scores in our peer group for We're Always Learning and staff engagement. So to give you a bit of information about what feeds into those, because lots of different questions, the We're Always Learning, that's around appraisals, CPD, so additional training, people do additional professional development, any other development that they do at the trust, and their ability to feedback on things and feed into discussions. So doing really well to have lifted our score in that this year. And the engagement score, that's around, the 3 centres around that are advocacy, motivation, involvement. So there are questions around that one were, do people feel they have a voice? Do they look forward to going to work? Are they included in department decisions? So really, it's really good that for 2 years on the run now, our staff feel they are high in engagement. They're able to share their views, really look forward to coming to work here, and that they have a voice. Now, within the people promise elements, there's some sub-scores, and we've got the highest score on 4 of those. So autonomy and control. And the questions around that were people feel trusted to do their job. They've got an opportunity to show initiative. They can make suggestions for change, and they can influence how the department or how their work is done. So people feel they can really feedback on how to do things. They're trusted to do their job, and they can make improvements when they need to. Appraisals, we know from the reports to the board every month we do really well on keeping our appraisal rate high, and that shows through. And one of the things to note from appraisals is there's a second sub-question to that, which is, did your appraisal help you to make improvements in your working life, in your role? And people are saying yes, that they did. So not just a tick box exercise, people are feeling the appraisals are adding value. Motivation score, again, around people looking forward to going to work. It's good news that we score high in that. We tried really hard over the last year to make improvements on our with everything across the trust within NHR, whether it's on just culture, so people feel that they're treated fairly, whether it's the extra benefits that we give people. So recently started giving people, you know, breakfasts and free teas and coffees and free parking, etc. So people feel really motivated to come to work here, which is good. And then finally, the involvement score, questions that feed into that are, can they share their views? Can they influence the work that's being done? So we know we've got more to do, but I think this is really positive. Really starting to show the benefits of the work we're doing in engaging with staff, in making sure people feel they can come forward, making sure people can feel that they can talk about how they want to do their job differently and that they're involved in those decisions. So we still have room for improvement. We know that this is not the experience in this staff survey. It's not the experience of every single member of staff every day, and that's what we really strive for, is for everyone to have the best experience they can every single day. We know that our staff survey is still not where it needed to be in terms of bullying, harassment and discrimination. We've got more work to do there, and we know that. So we've got ambitious plans this year to roll out program actions to help deal with that. We want to make sure staff feel they're able to raise concerns and give staff confidence that if they do raise it, we will deal with their issue. So we're looking at how people raise concerns, different routes available, how freedom to speak up feeds into that. So lots of work going on around that. Supporting staff with long-term health conditions. The survey has shown that we could do a little bit more in that area. We already do a fantastic amount there, but we know that there are some staff with long-term health conditions who we provide a little bit of extra support through occupational health. So we're looking at our processes around that. Reducing additional hours, we've talked about at length before at board. Improving career progression and promotion opportunities, making sure that they're open and fair. So again, that's linked into our programme of activities plan for the reduction of discrimination as well. So to do those two programmes in tandem. This year, it's worth saying we haven't put any of the bank survey data on here. I'll bring that back in a more detailed report through working committee probably. But this is the first year that we have had our bank staff surveyed as well. And the survey centre did feed back to us that actually we had one of the high return rates for our bank staff. Now, when we look at our bank data, the bank staff, their results are comparable to the substantive staff, apart from not unexpectedly feeling more included. If you think about it, the bank staff aren't necessarily linked to an individual area or department and can move around the hospital. So we're going to do some work this year on making sure that our bank staff feel part of Team MKUH and how they're included in the areas they're working in. And also providing our bank staff with opportunities for progression and development. We want to make sure that even if they just do one shift a month, that they have opportunities available to them too. So I think the message is it's a really good survey, really good to get some high national scores. That's fantastic, and we should really shout about that. But not forgetting that we do have room for improvement and we've got more work to do.
So I think two things. Firstly, Daniel has focused on the room for improvement as is right, but actually this is properly amazing in terms of these scores, and it's linked to the previous discussion around industrial action and good relationships and genuinely good evidence that there is this sense of one real team here in terms of staff community looking after our patients rather than sort of them and us management and stuff. So I'm really excited by this. My slightly more geeky question was around the people working extra paid hours. Now, normally when benchmarking survey, people would either say, a high score is better or worse, or they'd just say it's significantly different. And I think in reality, this is significantly different rather than better or worse, particularly given the context of the rest of our answers. So I'm pretty relaxed, and that shouldn't be read in like it should be great.
Yeah, thank you. No, I agree.
Yeah, Heidi, obviously it's a fantastic, it might be a fantastic result. But I think that is the point. I can't remember the exact words now, but you know, the fact that people feel they have a voice and that they're included, that will go on driving so much positivity that's obviously you know, hugely important to us, isn't it? That everyone feels not only that they're in the team, but they have a voice out up into how the organisation functions. So it's very positive. And I might get my DM on that question because I never like those questions in surveys where there's a sort of, you know, a twist that if you answer it one way, it means one thing, and answer it another, it means something else. So sometimes it's not.
I think it's also worth noting that this year, for the first time, we've had our survey with some extra resin from Workforce Race Equality Standard and Disability Standard themes and statistics to it. So we'll be working through those with the various groups and various staff networks and through the ILC, and I'll bring a much more detailed analysis of the whole survey through Workforce Committee.
Yeah, so that'd be good to see. And I suppose if, you know, using our appreciative inquiry type approach as well, you know, where we've got such great results, I suppose is looking at what we're doing in those areas and see how we roll those out. So we pull out the positive and really use it across the organisation so that, as you say, we can make sure, or as far as we can, that all staff feel exactly the same. So.
I think just on that, what the targeted work that we'll do this year, I mean, being really explicit about anti-racism, really explicit about tackling racism and discrimination in the organisation, and amplifying the voices of people are seldom heard. So we've got really great engagement, we've got a really good structure that works really well for lots of our staff, and we've got groups of staff where it doesn't work as well. So really doing some very specific work, understanding what will work, what creates psychological safety for different teams, and putting that in place. And I think that's really exciting. We can make some really great progress this year.
Does our staff retention and turnover rates correlate with the positive results of this survey?
So we know our turnover rate is higher than we want it to be. I think what I'd say is our survey is really good, and we can really use that to influence that if we really start to share with people. You know, our survey is good compared to peers. I would hope to be able to use that as part of my retention strategy.
So will you actually be using it to inform where you put some attention to those high turnover areas of the hospital?
Yeah, so what happens next with that survey is we get the report on all the granular detail by department, assuming more than 11 people in each department have responded, or else it's rolled up into the department above. So because we really have to make sure we maintain anonymity for staff when we fill it in. We work with those individual areas. We give them, share their feedback, have an action plan. So every single area goes through that. So yeah, absolutely.
Yeah. And I suppose just on that, the execs received a presentation from Danielle and the team specifically on band 2 workers in the organisation, where there is significantly high turnover, and that was stratified by ward, by ethnicity, by sex, by length of service, pretty much everything. So that level of granularity we brought to execs, had a really good conversation about what interventions do we want to make as an organisation in that or with that group of staff to reduce turnover. And so we've come out with a view about what we need to do. And at the very top of that list is to go and have the conversations with those different groups of staff to find out what they want, recognising that the delights of Agenda for Change are that you're very much constrained by the pay. So therefore, what else can we do to look after that group? So we absolutely did that. I was also going to make a separate point of it. It's not often I get told off by them, but execs, when this was brought forward, we did have a moment where we did what I think we're quite good at doing, which is focusing on where we're an outlier and saying how do we bring that up and how do we focus on that area and make it better. I think, and we went through around about 60 pages of pretty significant detail on the staff survey, and I have to say it was really boring. It was really boring because it was all green, and so we just sort of flicked through it. And it was actually Yvonne who said, I've just come from another organisation and I really want to enjoy this because I haven't worked in an organisation where it's all green. And so I think there is just an element for us as a board to take a moment to reflect on how good these are, and also to acknowledge the really hard work that lots of people across lots of different parts of Danielle's team, the work that Kate does, the work that the individual managers do when they get staff survey results and look to influence and improve things. And just as a board to say thank you, I think it really does show that this work is paying off.
Absolutely.
I suppose on that point, it's fantastic. Do you do the kind of, you said we did, is that maybe, because that's obviously helping improve those.
Yeah, so the staff survey is an industry in itself from this point onwards. So we'll split all the data out, we'll take it out to the team. We'll do a, you said we did last year, we'll do it at CSU level and at trust level. And then we'll look at an action plan for next year, and then that will drive next year's, you said we did. But we really relied on the managers and the teams to own it together, because it can't be the HR team or the manager fixing whatever the issues may be. It's really a team. As with everything with MKUH, it's a real team approach.
Absolutely. Thank you very much. Ian.
So personally, I've just been grappling a little bit with these two potentially rather contrary narratives. One is we've got a very positive staff survey. The other is we know that some of our staff experience discrimination based on race and other characteristics, and that's their lived experience. And I guess me just trying to put those two things together, if you work in an organisation where no one's engaged, the chances of there being a difference in experience and differential levels of engagement is really quite low. If you work in an organisation where generally speaking people are engaged, the chance of there being differential experiences are high. So for me, or higher. So for me, there is a sense that these are not mutually exclusive stories, and there is, as Danielle says, lots of room for improvement on that differential.
Thank you. Sorry, Ben's got a hand up. So
oh, thanks. Just concur with what everybody said about how fantastic the results are. Really, really positive. I'm sitting here glowing as the new chair of Workforce Committee, and look forward to seeing the action plans go through. The one question I've got, Danielle, is looking at the slide, it talks about comparisons with our peer group. Do we get the same information for other parts of the sector? So I'm thinking about, community, mental health.
Yeah, so the national results were published this morning at 9:30. So we can go on to there and see the results for all the other sectors. We won't get we are provided with the slide, with the graphs from the slides that you've seen. So we won't get them, but what we can do is we can look ourselves and see what the differences are.
Yeah, because it's great that we look there, but in terms of not that we're ever going to be complacent, we need to celebrate the success, but thinking about other parts of the NHS and other organisations that I know do really well on the survey. I'm thinking about one in particular, but that's not in acute. And are there sort of lessons that we can learn across the sector as well as within our own field of expertise?
Thank you. Thanks. Heidi, do you have a question?
Really following on from Ian's comment, but I was thinking, it's the point that you're right. They're kind of not necessarily too much pieces, but I think there's a momentum thing in staff surveys or the results and how a team and organisation are functioning, isn't it? And I think we can take that momentum for that huge cohort who are feeling very positive, because then if people are not feeling engaged, hopefully people can kind of have that space to think, well, what can we do to make that a different experience for these people? Or how do we take responsibility from us as a board right the way through to realise that's not the same experience, and hopefully that kind of gap, if you like, makes people stand back and reflect a bit more and say, do you know what, this really is. I mean, I loved your words 2 weeks ago about racism, and it's unacceptable. And I think putting it out there is, I'm not sure I've been that bold in my organisation, so I like to hear it and read it. But I think it's really important that we take the positive and think as a cohort of an organisation, we can scoop and pull those people who don't feel like that feeling by behaving differently, because we are an engaged team.
And it's underpinned, I think, underpinned with the allyship time. Okay, very quickly, because I'm just checking the agenda.
Just, well, with the work that you described earlier on, that sort of improving and increasing psychological safety, we might actually see more people feeling more confident about, describe, so some of the things were like you were saying, we skew going forward, which won't necessarily be a bad thing. It's having that confidence.
Just a quick one. I know I missed it, but do you know how many, or what's the percentage of response on this, on the overall staff?
So I think, my memory now. So in terms of the overall staff response, I think we're at 43%,
43 is what I've got.
which is the same as the sector. Some organisations this year have really struggled and they're down as low as 18%. So although it doesn't seem very, very much compared to corporate surveys, it is actually really good for the NHS.
Is it higher than last year?
I think we're 1% different, either up or down. I can't remember. It's about the same as last.
Thank you. Thank you very much. Okay. That's it. Thank you. Won't get hijacked because of this. Yeah, very convenient. 8, serious incident and learning report.
So the report is on page 26 of the wider pack. It's a fairly brief report, and I would have thought more questions than me talking. But essentially 4 serious incidents reported over the last couple of months. The second one in the table on page 26, I had to look at that and think, what was that all about? That was around a patient who came into hospital and deteriorated and developed diabetic ketoacidosis whilst in hospital because a relatively new and unusual medication wasn't stopped. And it should have been. So that was important learning around medicines, but it was a new and poorly understood medicine. More importantly, perhaps elsewhere in the paper, we talk about some of the really good improvement work that's going on. So thematic work around diabetes, which is quite personal given what I've just said, and then some QI projects in relation to medicines management, discharge summaries, and pressure ulcers. I would highlight a prevention of future deaths report, which I think we mentioned in January. We've received a prevention of future death report from the coroner. We have now made a response to that. That's the response itself will be on the agenda of quality and clinical risk on the 20th of March and continue to be circulated more widely. People will see. I'm sure both cases I can take. Any questions on content?
Great, thank you very much. Any questions? Sorry, oh, sorry, Dan.
It's just, I suppose, looking at more detail than is in that report. The pressure also stuff has been on our radar for quite a while, and not that radar, but
the board radar.
Yeah, the board radar for a while. So I was just wondering whether there's any data on if the initiatives that have been put in, is there any data on the improvement trajectory that we are on?
So I'm going to take Hospital Pass, which is there's an awful lot of work going on with Yvonne's leading on it, so I think it'd be far better for her to answer that question. Perhaps again, if we could take that to quality and clinical risk on the 20th and have a proper discussion.
Yeah, absolutely. And that tends to be where we have those really in-depth discussions around it and really look at what's going on. But because you were on that, aren't you? So yeah. Great. Okay. Any other questions? Just quickly around the reference to other things, it said, but the violence and abuse on staff, incivility to each other, is something that's
so we've
significant or?
So there's a little bit of detail on that in the risk report actually around staff incidents. We picked it up as a recent theme around reports of incivility. And in fact, there's quite a detailed report going to Health and Safety Committee on Monday, looking at every single incident. So we've launched our new behaviours framework. There's a lot of work that is contained in a cultural improvement programme around actually how do we really look at these different instances and where staff incivility really has been reported, and what we do with that, and where there is reports on radar that are more connected with HR interventions, for example. They might be connected with debriefing from a traumatic incident. Sometimes they're related to difficult incidents. So there's a bit of work we need to do and understanding some of the context of these, also being really clear about the standards of behaviour that we expect from each other, even when we're under pressure. And also sort of link the HR work around other interventions that we can make. So we're looking at every incident that's been reported at Health and Safety Committee in that category over the last few months to really look at it. It's mostly people reporting people being rude.
Yeah.
And I expect that it doesn't capture all the context.
No.
But want to just really be clear about it, because I think it's when we talk about our behaviours, we really need to be able to describe that this is not a behaviour that is acceptable in our organisation.
So I think as Kate's described, the exec team is interested in it and wants to understand it better. I guess, I mean, there's also just the sense that, you know, whilst there's never a wrong way to report anything, it's a slightly odd format to report concerns about incivility from a colleague through the clinical incident reporting system. So, you know, we'll also be interested in how sort of line management responses are going as well.
I'm sure I know the answer to this question. The board has seen the behaviours framework.
Yeah.
It has come through. Yeah, I just think it's probably worth sending that around with the minutes, because it is very clear about what we expect, but as importantly, what we do not expect.
Yeah.
I think staff really have valued that, not just the what we expect, but what is untouchable as well. So I think we probably ought to send that around as an action just to remind everybody in the board as well.
Yeah, absolutely. That's fine. Yeah, we did sign it up. It was very clear. Thank you very much. Any other questions? Thank you. Feedback from the maternity insurance group, which I'm undertaking today. Actually, to be honest, I think this has got an awful lot that we covered in there. Apart from the usual sort of governance aspects that we look at the progress of action logs and discuss any areas that haven't been completed. There was a report on the obstetric ultrasound services, basically highlighting changes and improvement following feedback. Some of these, as an example, around areas of using translation services and actually how broad those services are and can be utilised much more effectively, even down to having letters put into proper other languages so that people understand them. Also, it was interesting to hear that for people that do not attend on the day, they're now actually being rung on the day to find out what the issues are, so that actually steps can be taken very promptly to address issues in terms of people finding it difficult to engage. The new staff have been employed in the services, and some are in post already, and others are joining in September. So there's a real impetus on getting obviously more people through those scanning services as quickly as possible. There is more work still going on. Obviously, we had this paper, but operational colleagues have taken it away to have further discussions and see how further it can be improved. But it was a very good update, because it was something that was being flagged up at the committee as there were issues there. Lots of focus on mandatory and other training. I think that came across, and especially around safeguarding. And actually, the committee will be having a specific paper on that at the next meeting. So there was a good focus on there. As Melissa mentioned, the obstetrics, the doctors are now up to full complement, 16, so that's a real plus. Vacancy rate is now down to 15% from 17, so it's still higher than we want, but it's going in the right direction, which we were sure about. There has also been a culture survey with over 100 responses, which is a really, really good response. So there's a lot of analysis going on at the moment, but obviously it should be very interesting to see what comes out of that, and then the actions that we can take. But of course, culture surveys and we just been talking about behaviours and things, absolutely key. So this will be a really, really positive piece of work, and we can probably address some issues having been fed back by so many people, which is great. And also there is the trauma risk management team have organised some support for midwifery and paediatric staff who are involved in traumatic events. There's guidance that's come through, that's going through the governance process. But obviously this is very important because it has a huge impact on particularly on the individuals involved, but on the staff as well. So we want to make sure that staff are supported. And also, Melissa mentioned, I was going to just pull out as well, the weekday daily wellbeing walks, which seem to be making quite a difference. So it's a very comprehensive meeting, covered a lot, but there's a lot of very, very good work going on, people working extremely hard. So unless anybody's got any questions, which I'll probably hand over to Ian anyway. Thank you very much. That's noted. Sorry. Do you want to do it? Oh yes, actually, yes. Yeah. Well, should we grab yes, we'll grab have coffee or a tea and stretch our legs. We'll come back in 10 minutes. Is it?
I suspected that. No, maybe that's what I, yes, I would probably.
Item 11, the performance report. Thanks.
Thank you, Alison. So a number of reports in this month's pack. I will start off with the content and go through the performance against month 10, which is January. Then we can just address, we've been talking about the changing format and responsiveness to the reporting. I'll pick that up secondary. So I think for the month of January, just to be clear, was a difficult month in terms of activity levels continued, although ED attendances were down on January, so on December, so we did regain our performance in January. As we've consistently reported, we're delivering well against the national target. However, we could improve that and still do better, so no complacency and continue to do so. The ambulance handover position held. Pleased to report that we've managed to deliver 98% of people being seen in less than an hour, which was really, top draw compared to what was going on around the rest of the country, and 81% still within 30 minutes. So the vast majority of people have been moving through the ED department or into the ED department, and we've been releasing ambulances really well. Our bed occupancy, though, then within the hospital was very high in January. That's not an unusual position. We prepare for that most years. Usually the staffing numbers, the support from other community providers and in terms of sickness levels, etc., is a fairly silted up position, and that's reflected in our super stranded patients numbers. Our non-criteria to reside, again, the average in month was 82, but from memory in January we did get up to almost 100 patients on occasions, and our escalation bed capacity then in response to that was also very high. Our elective performance was impacted, continuing in January, so we've reported through here quite consistently that our day surgery unit has often had bedded patients within it, impacting on the number, and also at this stage in January we still had our ring-fenced orthopaedic ward was in the smaller configuration ward, 8 beds and not its usual 13, having an impact on performance. Diagnostics continued to recover in January, the constraints and pinch points still being around MRI and CT. And our cancer recovery again was on trajectory against our recovery position that we'd submitted into the region, and we continue to make improvements on that. We remain out of the sort of intense monitoring of being in a tier 1 or tier 2, so we were on that sort of cusp a few months back, but have continued to perform. And actually we will see a dip post January, but the dip is we've treated the patients, therefore they've breached, and they've then been discharged onwards. So it's a positive news story within that. I guess I'll let Terry pick up the finance issues later. As per Danielle with workforce, the turnover piece that we've continued was still high in January. And I think just for the record, then we've reported it in month previously, the safety targets, we've breached a number of those, although they're internal targets that we've set ourselves for the year. I'm happy to pick up any questions on the sort of performance content, then we can maybe go on to a discussion just about the different reporting formats.
Great, okay, thanks, Anna. Hi.
I think my question comes now. I'm not sure. Do we have any rationale for why only 5.8% of patients did not attend, seeing that as a positive? What's made that positive where it hasn't been? It's been over the 6%, hasn't it?
Yes, I think the rationale, we're beneath the threshold.
Yes.
Yes,
We're
yeah.
in a good place.
We
Really,
are,
from where
we
we
are.
have been.
Yes.
Did not. Now, I just wonder whether we think we done some specific things to make that different.
I'm not convinced
That we have
specifically. I mean, we've been working behind the booking processes I suspect most of it, we've been working on the technology and trying to do the follow-up stuff differently.
I just wondered
And the
how assured we
technical
could be that that
minds
would carry on then.
Yeah, I think we're floating around between 5 and 7% at the moment.
Any other questions at all? Okay.
Just wondering on the NICE breaches, the 35 in 1 month. What's behind that?
So a NICE breach isn't quite as bad as it sounds. It's usually essentially a diminished delay in terms of taking a very large document and standing it. We tend to see a bit of a spike every winter when many of our corporate clinicians working primarily in corporate roles go back into the award start. I asked that very question last night in preparation for quality for the risk committee. So I will feedback.
That's funny enough, that's one of the questions I had. Any other question? And the only other thing, Emma, was around this 78-week.
Yeah, sorry.
Yes, not
Position for
the position around there, because we're not quite where we want to be.
So no, sorry, I should have mentioned that. We have declared externally that we believe will be 25 trauma and orthopedic breaches by the end of March. I think I would just caveat that with the cancellation next week in terms of the industrial action junior doctor strike. I suspect that number will somewhat. And again, I think that's been challenged. We are being asked to submit as we speak today, beginnings of indication on that cancellation of activity next week and Monday to Wednesday. So we've got a meeting after this to really go through the final details. But the premise is that we keep all the emergency services, high risk areas running. It's inevitable that we're going to have to, over a 72-hour duration, take down some outpatient activity where we've drawn the doctors into the main hospital, and our elected position, whilst I'm pleased to report orthopedic lists will continue, and we've done some high volume, low complexity case numbers now, which is putting 10 on the list. Those sorts of things will continue with cancer and urgents and vacancy stuff.
Yeah.
It won't be much more than that.
Right.
It'll be a big impact next week.
But we've managed to get rid of over 100.
Yes, 142.
Sorry, I just wanted,
Sorry.
I just wanted to say I love the format of the new look. It's really, really good.
Okay. So I was going to come on to that.
Oh, sorry.
No,
we're not there
it's
yet.
fine,
I
that's
wasn't
fine.
sure where we
We're just doing
We're dealing with the content of the business for
Sorry.
the old stuff.
Yeah.
But then I suppose it was opening up. I know we've had some various meetings and John and the team have been working hard in the background on the new format. So let me hand over to John.
So you have a selection box to these. They've gone to their respective directors for them to put into the comments. And we'll send out the rest in a day or so. You'll get both reports for the next 2 months, for this month's pay. You'll hold both reports until the end of the year. Ian and I had an interesting conversation yesterday about whether or not these reports gave the board sufficient assurance that all is well. The conversation is along the lines that these are picked by the executive, and therefore, if we didn't want to show you something, we have an opportunity to show you something. And then, therefore, whether, for example, the conversation we just had about nice breaches probably wouldn't have been on these reports. And so, whether or not we want to perhaps continue with showing the one page in addition, perhaps losing all the graphs off the bottom because they're, we can give access to that on the internet or something, just to keep all the papers down to inspect them. And the question is, does the board think that they will get sufficient assurance, or actually would it be best to have access to the larger sheet just as well? But this sheet replacing the narrative and your intention to what is actually the executive think is important issues.
Yeah.
So if I just, given that conversation, if I just put my own perspective, I think the new format is great in terms of focusing conversation and making sure we understand key issues about specific variables. But it is really important for me that as a unitary board, we get to see that wider sheet of performance metrics rather than there being pick and choose on behalf of the executive presenting. And I say that as a non-executive in another organisation. So I think it would be laziness not to have that, frankly. I understand why people may or may not want to see it, but I think we would be doing our job collectively if we didn't see that snapshot picture as well. The new format helps us guide the discussion. And the nice thing is a really good example, but I wouldn't mention it.
I personally didn't think we were going to lose it. I probably misunderstood. I thought it was just going to go to the appendix. And,
Yeah.
That would be. And we can do that, but the original intention was that this was a new format to replace it, not as well as, but it has required it can be popped down as an appendix.
Yes.
To be looked at.
Yeah.
At later.
I think, yeah, it's good having that access to it, but without making it a substantive bit of the body of the report. So is everybody happy? We take that, we go with the new format and then have the things in it as an appendix.
We did say that we double run next month because we haven't seen full slate
And the month up, we'll finish off this
till
year.
the end of this year.
Yes, yeah,
And then
absolutely.
drop into the.
No, that's good. Leave it.
Just one minor comment, there's the circles in the graph. They're key.
So we have also got access electronically, which is actually very much better because as you hover over an individual point, it explains exactly why it is a common cause or special cause variation and whether it's in or out of control. I think everyone has access to it.
Yeah, as long as we can, if we can click on it and see what the explanation. I did once many years ago write down all these, the next to all these symbols, but I've lost it.
But we again, so last month we put inside, I think Julia is sort of pointed it out to you, that there is a sort of document holding area inside iPad.
Oh, yes.
For example, the glossary is in, and might be a good place actually, Danielle, to pop the behaviours document so that it stays in iPads if you want to review it. But we can also explain or put in there an explanation of how all the error markers work.
That would be great, actually, yes. And then we've got one point. That's really, really helpful because then we can populate anything that, you know, what any of us sort of say, always keep forgetting what that acronym is.
Yes.
Great. Okay. So good. Yeah. Thank you very much. And thank you for the work that's gone into revamping this thing. Any other questions on the okay. Finance, Terry.
Thank you. So we have in front of us the month 10 report, so that covers period April through to January. The income and expenditure position cumulatively is a 2.8 million deficit, which is marginally off of plan. And the trust is continuing to forecast plan achievement for the end of the year, which is a break-even position. The achievement of the break-even position is relying on a lot of non-recurrent mitigation, and the main reasons for that are that we are spending more on planned care capacity as part of our elective recovery efforts than we are receiving in funding for that activity. You've heard me mention previous months that's because of the policy change in year from NHS England that is effectively underwriting baseline values at each organisation, and there isn't any monies officially being paid through for overperformance. The principal reason for that is that your average hospital, most hospitals this year, aren't achieving the activity plans during 22-23 and would otherwise have lots of funding clawed back from their positions, but would be exposing lots of deficits up and down the country, and therefore this money is there principally to support costs and is acting as deficit support. We are achieving the activity plan for this year, so we're forecasting for the elective side, for instance, that we're going to be meeting the 104% activity target. But because of that change, we're not going to be formally qualifying for any additional fundings. What I'll say to the board is there's conversations going on as part of the year-end preparation and wash up to see whether there are monies that can flow in recognition of the work that we've done, particularly when you look at our performance on the planned care side relative to peer group performance, and that hopefully will be something positive to say around that into the year-end. Just in terms of the operating cost position, again, we've got, for reasons specifically around the workforce position, so vacancy, sickness, extra shifts completed to support the waiting list recovery, and indeed, Adam touched upon some of the escalation costs we've had to get us through the winter period, which seems to extend every single year, so pretty much all of autumn and through winter. So we've been incurring costs in excess of budget on the pay side. We've talked about, particularly in the finance committee, I'm sure the same has been discussed in the workforce committee, there's a lot of interventions this year to try and unwind some of those premiums, most notably around the vacancy and the both international and domestic efforts to get the recruitment and substantive fill rate up, which should unwind some of those premium costs into next year. We've got, again, relative to peers, a fairly decent performance on the financial efficiency side. So you can see in the report we're tracking to about 70% of our target. That is above peer group delivery for this year, but nonetheless we're seeing the same issues that pretty much all organisations are grappling with around a residual shortfall against that target, and both how much of those savings, sorry, the proportion of those savings that are recurrent cash out delivery. So that's at the moment that is showing as a brought forward shortfall into next year, which will put pressure on the underlying financial position into next year. So lots of work going on around improving that and seeing in specific discussions with divisional teams how much of that non-recurrent delivery could convert into permanent, but there is likely still to be a shortfall into next year. We've got a separate presentation coming on planning progress into next year, but I guess what I would say is that those issues, specifically the elective recovery funding, is evolving into a different type of challenge for us next year. There's lots of conversations in the diary with both NHS England nationally and local system partners to see how we can work through some of those to make sure that we have the right set of incentives and funding arrangements into next year to pay for the cost of that activity. Moving away from the income and expenditure position, looking at capital, lots of work going on. So just to say thank you publicly to the teams involved in that, to make sure that we're landing all of the various schemes. We have over 100 capital schemes in the organisation, and we're just pacing those through to year end to make sure that all of those arrangements are in line, and that's progressing well. There aren't any obvious cash concerns for this year, so we have sufficient cash available to service liabilities. And yeah, I think a lot of the focus now is turning to getting set up in plans for next year. So I'll pause there and take any questions.
Thank you very much. Thanks. Any questions at all? I did
comment to think Terry and his team and the work has been incredibly what they're doing, particularly in terms of the number of capital that's being put through, but also working hard to see achieve best position with change we saw in the mid-year. Obviously, the electric recovery.
Yeah.
So I think has put a lot of work and pressure on lots of people across the directors, so particularly the finance team being working very hard to get to the best place possible. So
yeah, not helpful having goalposts changed mid-year. So any other? Thank you very much. As you say, we've got. Oh, sorry.
I put my hand up. You didn't just flash it out. Just a note on the Better Values programme, and I think you were saying opportunity for the new financial year. How promising is that looking?
So we're seeing at the moment, I mean, the exact level of savings required will depend on where we get to on some of those funding conversations. So that's still a little bit of a new piece. With what we've seen so far from teams, we've got ideas and proposals coming forward that would service about half of the working target that we're planning against. There's been a really good engagement from teams. I mean, there's a lot going on, generally speaking, so the bandwidth very obviously is a bit constrained with other priorities, but there's lots of workshops going on with divisional teams. I think some of the stuff we'll be doing in the next 2 to 3 weeks as a kind of corporate conversation, looking at some of those hand trust interventions that we've taken. That's probably an area we want to catch up on, but otherwise I think we're in a relatively good place, but very obviously some of the issues we're grappling with, and I'll just draw one out. I mean, the inflation challenge going into next year is at every turn exceeding the level of funding available. So I think when that was settled as a funding award last autumn, it was kind of working to a position of about 5.5% of inflation in the economy. We are seeing lots of things coming up at the 7, double-digit type percentages plus local offers. So every pound that we're able to try and see as an efficiency opportunity is immediately being consumed as a contract falling due for renewal. Now that is a part of the conversation we have with the national, i.e. the ability of an organisation of our shape and size to mitigate all of those headwinds. I think it's probably not realistic to assume we consume all of our own smoke on that front, and that's the point that we're working through both the system partners and the regional agency.
Thank you very much. Okay. Well, yeah, lots more discussions over the next few weeks. Workforce report, Daniel, thank you.
So just a few highlights from the workforce report. Our vacancy rate continues to fall, and we now have the highest number of people in post we've ever had. So we've got 4,075 people in post. That's an additional 200 people on the previous year. Our absence continues to fall, which is great news. We hope that trend will carry on. Our retention and turnover. Our turnover figure is now starting to slow. And so we have seen it rise consistently this year. It's the increase is slowing, which is good news. We've talked at length in this group, I think, Workforce Committee before about that. It will be slow to turn. The work that we're doing typically has 3 to 6 months before it makes an impact. We're starting to see some of that coming through now with the areas that we targeted our initial retention and improvement toolkits in. We've rolled it out across the trust, and the HRBPs are working hard with the 3 top areas in each of their divisions, and we're starting to see that have an impact now, which is good news. We were asked at the last board to put in the paper the cost per hire. So we've calculated that. It's about £240 per post at the moment. And that includes all our advertising, recruitment, so visas, DBS checks, etc. The only thing that doesn't include is the international nurses, because they're funded by a separate business case. That's your information. Statutory mandatory training continues to do really well. We continue to keep the pressure up on that, and it's good that that stays above our target. Our nursing vacancies down to 68, which again, reduction from the previous month of 30. So again, really, really good news. We're starting to look at making some efficiencies within HR as well. So we're looking at some automation, taking some of our paper forms, making life easier for managers as well as the team themselves. So we're working through that. There'll be a number of those to come forward over the next few months. And one thing to note from the hot topics is we had a consultation recently to change the pay date. We brought it forward by a couple of days. The reason for that was so that it gives us time to run what we call a supplementary pay run. So if a member of staff was not paid correctly because of a late form or like late expenses claim or something like that, what would have happened previously was they'd have to have raised that and stay if they really needed a faster payment to rectify that, which is it was calculated manually, so it has tax implications. Its taxes is the highest tax rate. Terry's team have to put that through manually as well. So with the move to the new payroll provider, there's been an opportunity to implement a supplementary pay run, which is what most trusts, other trusts do. So we'll be able now, by moving the pay date forward a couple of days, to get that in by the end of the month. So should anyone not be paid correctly, we have an opportunity to correct that before the end of the month. So that happened this month. And we've covered the industrial action already.
Thank you very much. John? So, I'm really interested to hear the cost of hiring 240. I have no idea whether that's a big number or a small number. Do you have anything which would help us?
Yeah, so I think I provided it in pounds because that's, I know we've reported here on time to hire, which is what the NHS traditionally use. The board have asked that we do it in pounds. I don't know whether that is relative to other trusts, but I do know in the time to hire, which is what the metrics the NHS use, which is already in our report. We do have more work to do. We can get people in more quickly. And then obviously cost of recruitment will come down if we do that, because we know we can lose people if there are unnecessary delays.
Actually, picking up on that point, is that I was going to report it onto my ILC feedback, but around the 3 new posts to support with recruitment.
Yes, so they're not in here because we've not got these in.
No, they're not there yet, but that's the plan, isn't it?
Yes, so we've put 3 new posts in, whose role is twofold. One is to help the recruiting managers, because if you don't recruit very regularly, then using our systems can be difficult and challenging. So one is to do almost a sort of like a professional recruiter role. So to help the recruiting manager make sure all the paperwork's there, get the role advertised, liaise with the recruitment team to make sure that happens, talk to candidates, do basic long listing. They can do shortlisting if the recruiting manager gives them the criteria they want to shortlist against. And then to make sure when they then move on to the interview stage, shortlisting stages, that everything that's being done is fair, consistent, because we know that what one manager will grade someone high on for an application, someone else might not. So it's to make sure there's consistency across all the applications. And then when we come to the recruiting stage, to be on the interview panel, they'll have been trained in all the recruitment training, so unconscious bias, how to do recruitment. So we want them to be on the interview panel as almost like an independent representative to make sure that when the interview takes place, consistent and reasonable questions, that they make the relevant notes that are needed, that the deliberations in the panel between the panel members, of which they are also a member, are correct. So we're advertising for those roles now. The adverts are closed. We had a really good response, so we're hopeful of getting some really good people. It's worth saying that we've put that in, and we'll review that in 12 to 18 months. But yeah, when they come on board, I think they'll make a real difference to the speed of recruitment and both the manager and candidate experience.
I think the committee were, they felt there was a real plus, really good move. Jason, did you?
I would just again to John's point on the average possible hire for large employers in this area, it's around 190. So we're actually pretty close to it, which is a good thing.
That's really helpful. Yeah.
And I think in terms of time to hire as well, we're not too far out from quite a lot of employers here.
Yeah.
There was a couple of notable mentions who were like super fast, but they work in the tech space, and they know that they have to see people extremely quickly.
Right.
So that would be really a good comparison for us. Yeah.
Well, we are constrained by NHS employers checks, so we have to do the DBS check, we have to do the professional qualifications checks, and what have you. So
yeah, there's those extra layers for us.
It's good to hear that even with them, we're not too far off.
That's great. Thanks, Jason. That's really helpful. Thank you.
Thanks, couple of questions, Danielle, on vacancy rates. I mean, firstly, it's amazing, I think, to be under 10%. So massive kudos to you and the whole team to do that. Still worrying that the HCAs or what are the additional professional scientific, or is it additional clinical services is still really high. I was wondering if you could comment on that.
So there are, Joe mentioned earlier, we've done some a review of our band 2 rules. That is them. It's a multitude of things. So I think when we looked at that workforce, I think they break down into people who are looking for a job, and that might be with us, it might be with retail, it might be with warehousing, it might be with logistics. And so we find that those people will move quite regularly. And then we've got people who are working for us whilst something else is happening in their life, whether that's training and they're getting experience because they want to go on and BA something and they need hospital experience. Students working to earn some money between courses. People who've taken a step back in their career, want to do a fairly low stress job that has flexible hours that can fit around whether it's carers' responsibilities and will later go on to, at a different time in their life, step back into the career that they. And then we've got the people who do the job because they really, really love it and they will stay here probably for the whole career. And so we've been doing analysis on those groups, and as Joe says, we're going to be going out talking to people and understanding what's of interest. I think though that group of people who just want a job and will move, so when Amazon say join us and we'll give you £1,000 sign-on bonus, they will move for that. We do know though that they come back again in the spring. So I think we will always see high turnover in that group. What we need to do is make sure that those people who are working here while something else is happening in their life, that when they are ready to take whatever that next step might be, we can do that here with them. So support them with their training. And the people who are here because they really love the job and will do that job and progress up the band in that role, we need to make sure that they are happy, developed, and that they feel challenged in their work.
The last question from me, the 0% on medical and dental also kind of jumped out. And I looked at the model hospital last night, and it looks as if we've got a really high weighted average unit. So the cost that we have to look at this page. So what that said to me, or what that suggested, and please do comment, is that we're paying our doctors too much, and that's why they're coming here, or is that too simple?
It's far too simple. It's disappointing that's the conclusion you've jumped to.
And I will support Ian on that, by the way. It's not just
so probably is a longer conversation, but the sort of headline, we think, so we've been aware that we're at the top of we're the most costly on medical staff per weighted activity unit of everybody Model Hospital chooses to show. Brackets, they've cut 10 off at the top for various reasons, which is interesting. We think it's because the number of trainees we have here who have at least half their salary paid for by the deanery is very, very limited compared with most other trusts, certainly in the south of England. So the trainees we do have, quite a lot of them are fully trust funded because of the history of when those posts were created. I think that's probably what's pushing it. Detailed conversation. That's a scandalous conclusion.
I have to say, if I can come in there as well, the absolute support here, the fight in early 1980s, 70s, and subsequently to get half paid for training posts out of the organisations around us in the Thames Valley. That is a big, big factor. I think we can assure the board that we do not pay our doctors outside of the national pay rates, and we don't make exceptions for giving people golden awards and things like that. So we follow the rules. There is a systemic issue that we have been, and in particular has been investigated for a period of time.
And lobbying.
And lobbying hard.
With extensive success recently with the new dean.
Just to say, it's actually supported, which is unusual. We have formally raised this with the model hospital to say, we don't understand it, can you help them? And they can't. They don't understand, they can't help.
So we don't know why they've taken those 10 on.
So one of them is a large trust in the north that employs every single GP trainee in the country. So understandably, their weighted activity per doctor will look pretty dodgy. But there are another 9 which we don't work.
If you have the time, perhaps you'd be glad to have this as well.
I suppose it is an interesting point though. So I hope at a different level, it assures board members that we to look at this data and we do get into understanding the variation in it. So I think if we'd all sat around the table and gone, oh, quick, okay. We don't spend all of our time doing it, we can do more, but there are some very clear ones that you get into.
Yeah.
I think just one other comment, not being defensive at all, but when I started here 7 years ago, our vacancy rate in medical staff probably would have been 10–15%, something like that. Not me, but things like this building, the medical school, we've worked really, really hard to build our substantive staff and reduce our reliance on banking agencies. So it's a very positive story that our vacancy rate is 0 or close to 0.
Yeah. Thank you. Thanks for the question. Okay. Any other? Jason.
I was just going to make a little point on staff retention, which I'll probably talk about more in my thoughts in that sense, especially for the lower end, because we talk a lot about losing.
Can you speak up a little bit?
I was like, about staff retention. At the lower end, what the market is saying in terms of insight is actually, aside from things like the culture of the organisation and talking about investment in their career and future careers, one of the big deciding factors as to whether people stay at a lower grade in a bigger organisation for longer than a year or two is how they were onboarded. So their actual the engagement they receive through the recruitment process, and the onboarding and the orientation side of things is really crucial to get right for obviously for every layer of staff, but certainly for the lower bands that makes a huge difference in whether they stay or not.
Right. Okay. Yeah, as you say, that would be good to explore further in workforce. Thanks. Okay. Thank you very much. I'll just do a quick feedback. We had the Inclusion Leadership Council this week, hence a verbal feedback. We started running with the new format, the new agenda, which I think we brought to the board in January, and that seems to be going well. Just to acknowledge and also thank the BAME Network, they invited the CQC in to have a discussion with them, and there were positives coming out of it, including pastoral care, which was really great to hear as well, but also obviously other areas for further work. And when Samson gave some feedback around it, the point he did make was that the areas that had been raised were all ones we're aware of and we're already working on. So from that point of view, it was positive because we know we're not missing anything. But it was good, and the network took that initiative to, and that's just the sort of thing we want to encourage people to take the initiative to do these sorts of things. There's piece of good news. We now have Vanessa Holmes sitting on the committee, because in a conversation I had with her, it turned out there was some national NHS charitable funds which needs to be used for staff. And of course, you know, with our ambition with networks, if we can access that money, that can really support the networks with taking other pieces of work and projects forward. So that's going to be explored further, but that's a real positive actually. So we've got we can tap into other things outside the organisation as well. It was also noted there's significant involvement of staff as well as patients in research going on in the organisation. I think it's acknowledged externally as well that there's this hospital does a huge amount. But it is the engagement with staff as well. I mean, I know from some that I've spoken to doing PhDs and masters and all sorts of things. So there's a huge amount of work going on across the organisation. We had further discussions around development of the networks and things like succession planning. So really looking to the future and making sure that, you know, there is the interest and staff stepping into roles in the networks as and when they're required. And it was also noted around I think it's called intersectionality of the networks, in the sense that members of staff will be, you know, in probably one or more of those. And that's something we need to consider when we talk about networks and also how they all function together. We need to recognise that and not forget. Danielle's mentioned the potential recruitment of 3 new people to help with our recruitment process. And those were the main points coming out of the meeting. Any other questions? Okay, thank you very much. Going on then to the risk register report.
Yes. I think the actual risk registers themselves are contained in appendices towards the end of the pack. So there's an overview risk report. And in fact, we saw this same report at the Executive Committee yesterday and had some questions about risk 182, which is profiled as an overdue risk, but we were concerned actually about the general, about how the risk was had come about in the first place. So we went on to do some work around that. The overdue risks, because the scale is 3 out of 4, look really high, but they're actually really minimal. So some good, you know, kind of movement on the risk register. It is a dynamic document. It is updated. There is lots of movement in the divisions tracking risk and actively managing risk. And then just down at the sort of bottom of the report, into the report, there's some key risk indicators, and the risk team are doing some analysis each month that's slightly different around just a sort of key objective and some of the risks and incidents that have been logged through the radar system and what that looks like, what kind of profile is giving us. So we talked a little bit about this one earlier around incidents to do with sort of staff abuse, accidents, and what our actions around that, what that trend is doing, and whether we are, you know, there's more we need to do around interventions to support reductions in these incidents.
Thank you very much. Any questions on the paper?
Just a general one, if I may. Sorry. There were issues around people feeling comfortable kind of logging onto radar, just getting used to radar and things like that. Have they pretty much been resolved?
Well, there's 2 issues. There's 2 issues that are combined. So radar, so actually as a risk system, it's quite easy to use. The issues actually are with the incident reporting element of it, and it's radar being a new system, but it's also the introduction of learning from patient safety principles, national board. We're still one of the only trusts in the country to be using. That adds another form. So once you've finished completing an incident report, then it drops, if it's a particular type of incident, it drops down with some more questions. I sat and did an incident the other day. It's kind of 10 minutes, but you know, it's not a huge length of time. But if you've got through it, if you're, you know, busy on a ward, you know, and you're not familiar with the reporting system, there's bits that you can stumble over, and one of them is a body map. It sounds like it should be easy, but actually it's you know, unless you know what you're doing with it, it's just something that you can easily get stuck on, and then it stops you completing this report. So we're getting rid of that. We're also working with Radar Company and the national team to amalgamate the support so that it's more than 4. The national team, as I've said before, want to collect a lot of information because it gives them high quality data about incident reports in the country. But it also means that our staff spend more time on reporting, which is a fact, which we know is a significant factor in terms of willingness to report. There's more time out there doing. So it continues to be a lot of work with the national team and with Radar and with our risk and governance team around trying to make this as good as it can be. All other trusts this year from April will have to start introducing this. So we've been running it for, doing all of the testing work and doing all of the iterative change work. So we've put a lot of legwork into the system. Just as a result, we find it a lot easier and smoother.
I do.
I'm more confident. I'm reading the report, really good to read. And I read at the bottom, I kind of went back to the top and like the two new risks. And I read them and I kind of had an and I thought, well, I don't think at the board I need the and, but I don't know what your reflection on that is.
Yeah, that's good.
Yeah. It sort of talks about, the trust reputation, the Alliance Trust could be fines could be picked up. I know there will be and actions happening.
Yes,
so I suppose
there is.
I
suppose that it makes you do the work yourself of going into the risk research,
yes.
Finding the risk,
yes,
and mitigations.
Yes. But that's fine. I think
that's we can include the whole risk on the just the
Yes, when it's overdue. You have a question, Mark?
Yeah, I mean, I'm new, but I would find it much more valuable assessment if I could net off the mitigations against the risk, because this is the kind of gross, if you like, risk. Then there are mitigations, and then you end up with your ultimate exposure based on the effectiveness of the mitigations. So it doesn't, as a new net, doesn't really give me a sense of just how risky the risk is.
Yeah, so we've tried different versions of this report because one of the issues we have at board is that the significant risk register and the corporate risk register, which are contained in the documents that you've got as part of the pack, are enormous because we're a big complicated organisation, and so all of that is in there. But it's just we've tried to do these summary reports in a way that prevents us from having to go through hundreds and hundreds of lines of Excel in sort of exported spreadsheets. In order to do that, it's not quite there yet, but it's sort of closer to where we perhaps want it to be. But yes, agree. That's what we need to be able to demonstrate.
Yeah, it's kind of interesting, but I think that's the point. I think it's okay for, as long as we're noting as a board, we know where it is, and we know that it's done in that way in that process. I wouldn't want someone new or external to read it and think, well, that doesn't give the assurance or the question answer, because we do know it's there. And I think that's what we're agreeing as a board, is how we're reporting it.
Yeah.
Unless, of course, understand if someone's saying.
Yeah, we can do some work on this to look at, what actually, so we've picked overdue as something that we're concerned about, but actually it might be instead the better thing to escalate might be those without, adequate controls, for example. We can do some work on that through the audit committee.
I suppose for me, it's what's the implication of being overdue? Is that then significant? Because we've got the details of the risk. There's obviously mitigations there anyway, but does being overdue have an impact in any way? I suppose that's what went through my mind is a couple of months more or less. So okay, so what's the implication of that really? But,
so it's the controls have deteriorated. Its risk of materialisation is greater because it's not been reviewed. Yeah. So it's become more of an acute risk.
Yeah.
But as I said, it might not be the most helpful measure.
Yeah.
And we had this not a similar discussion, not quite the same, but at Tech yesterday.
Oh, right. I'm just wondering, in terms of with some of the reports, and it's something I was familiar with elsewhere, is sometimes when you've got the sort of synopsis, but now I'm going to probably use a wrong term now, but is it a hyperlink or something, but something that you can click on and it takes you to the body of the report, which then gives you the explanation, just in terms of not having to sort of try and rework narratives, but actually then direct, it's a bit like with you, Mark, you would be able then to click on it and go and see what the mitigations are, so you get that clarity around. I don't know whether that's, hopefully that's not too much work, she says, not knowing anything.
Yeah, it's that line between where it's the committees, the time to do that is at a committee level.
Yeah.
I'm asking myself, well, this is a public board.
Yeah.
Should we make it easier and more transparent? But I'm going to reserve judgment on that for
I guess it's the board in public. I think
Yeah.
it's slightly different because it is still, us working as a board and it's open to the public. So I suppose, there is a balance as to, if it's purely for public consumption, that I think we would have a slightly more open influence. Yeah. Yeah.
So I think just on the transparency, so I think we're very transparent and we put it all into the public domain.
Yeah.
And so all of our risks in the public domain. I think the issue is around then the navigation through that, so how this summary report helps to navigate through sort of really large complex documents.
Yeah.
Lots and lots of detail.
Thank you very much. Thanks, Kate. Then going on to the board assurance framework.
Yeah, no significant changes on the board assurance framework. There's a slight risk score adjustment down 20 to 15. Otherwise, I don't think there were any other changes in the period.
Anybody have any questions or comments on the board assurance? Thank you very much. And then I won't go through these individually, but under 18 we have all our summary reports from the committee and from the PEC as well, I think, don't we? Yeah. Any comments on those? Otherwise we can note. Thank you very much. And our forward agenda planner. Any, just actually going back to your point, Joe, around the, just lost on, it was the, thank you, patient experience. And what's it, there was a risk,
Something that's 2 months time.
2 months.
Patient experience.
Yeah. Yeah. That was it, wasn't it? Yeah. Just to make sure we've got it on the agenda as well, but going forward, thank you very much. Any other queries on that? Okay, I haven't been advised of any questions that have been emailed in. Thank you. And so it's just to pass motion to close the meeting and we will reconvene.
You start at 1:45, you've got interviews as well.
Yeah, do we want to start a bit earlier?
So I won't be able to attend, I've got CTGPs.
Oh, okay. Yeah.
You go 1:45.
1:45, everybody be happy with that? Yep, smashing. Okay, thank you all very much. Thank you for your time. See you in a bit, Beth. Jolly good. Now, I've spoken to the meeting just in case, because it's supposed to be talking about CO2.
Yeah.
So just in case.
So that.
That might be time. I don't think.